Okay, good afternoon, good evening, good morning, everyone. Welcome to Wednesday VMR. It's Alec and Mengyu today. We're very excited. We have our lovely Himun who will be presenting a case to us today, and Amal's going to be doing the scribing, Elena's doing the teaching points, and really looking forward to tackling the case today. We got the whiteboard up, and I guess we can get started whenever.
Okay. Chief complaint is painless jaundice. HPI, 75-year-old woman present with a 1 week of painless jaundice and weight loss of 20 pounds for a couple months. She also reported 3 days of abdominal distension, nausea, and non-projectile vomiting. I will stop here.
That's a great start. So I'm going to start with the first aliquot. So whenever I hear painless jaundice, so first when I hear jaundice, I automatically transmit that word into hyperbilirubinemia, and of course we know there's indirect and direct hyperbilirubinemia. For indirect, we think mostly about hemolysis, but some others, and for direct, we kind of focus on more around like hepatobiliary intra-abdominal. And here, I think with the addition of the abdominal symptoms, I think our thoughts automatically kind of focus a little bit more on the intra-abdominal process. And then here and from there, it kind of there's whether it's an obstructive process or intrahepatic obstruction or extrahepatic obstruction. Like we kind of have to rule the extrahepatic obstruction first with imaging, and then if not, and depending on I think the labs there will tell us a lot to guide us on the next step. But I'll pause here just for now and see what Alec has to say, and I'm sure he will tell us more information to help us find a direction further.
Awesome. Thanks so much, Mengyu. I don't know if I have too much to add. I think the fact that you're seeing the yellowness tells you the bilirubin is above 4 likely, and that coupled with the nausea and the vomiting certainly points us likely to an intra-abdominal process, hepatobiliary and etiology most likely. But there, just like the other case last week, could be multiple different things going on as well. I think something that strikes me is the patient's age and what that increases the risk for. And then I think the time course is really interesting. Most people don't get jaundiced in 1 week, right? Or most people don't lose 20 pounds in 1 week. So, if this is something that's significantly acute, or is this something that's more pseudo-acute and it's been a more subacute to chronic process that's now just sort of making its way to the surface, I think is going to be interesting to clarify and get more information about. And certainly the background of the patient and other associated symptoms will help us make diagnostic progress here. But I think activating your schema early of thinking about hepatobiliary etiologies of jaundice and whether that's extrahepatic, intrahepatic will be very interesting. And it looks like Himun is clarifying that the weight loss is over a couple of months. So certainly we get a more subacute flavor to this, which seemingly fits a little bit more. But yeah, I think beyond this, it'd be really helpful to get a little bit more information about other associated symptoms, the past history, and then definitely the labs will be revealing and kind of going from there. So Himun, would love to hear more.
Yes, so I just want to make sure that the abdominal distension was really quite a trouble for her. That's why she caused nausea and vomiting because of that. And she reported dark urine and clay color stool were noted. And she did not report fever, chill, shortness of breath, abdominal pain, constipation, gastrointestinal bleeding, or pruritus. Additionally, she experienced problems with the altered sleep rhythm, but no confusion or memory loss. She denied alcohol use, prior hepatitis, or blood transfusion, and there was no recent trouble. And past medical history, she had ocular surgery 30 years ago, and she had atrial fibrillation, and she's using medication Apix-7. And the social history, no alcohol, no smoking, housewife. She lives in Utah. And
Okay.
I finish here. Yeah.
Okay, thanks so much, Emun. Maybe, Menu, I can just sort of tackle the rest of the HPI and I can leave some of the past history to you. But the abdominal distension and the acuity of which certainly provides additional evidence to an intra-abdominal process. And the abdominal distension, the schema that I really like to use is a solid and liquid and gas phenomenon, gas being, distension of the bowel, frequently from constipation or for something else, solid being a mass, and a liquid being from ascites, for example. And I feel like a lot of these could be at play, but the dark urine and the clay color stool certainly would make us think about direct hyperbilirubinemia, because that would cause discoloration of the urine, which the indirect would not. And the clay colored stool you get is because the bilirubin's not in the stool to change its color. And so certainly would think about an obstructive process, but where that is a little bit less clear. And then, doesn't seem to be a clear inflammatory component otherwise, besides the weight loss, which seems to have a subacute flavor and maybe our only signal for inflammation at this time. And no evidence of bleed. And then, she already let us know ahead of time that there's no significant alcohol use history, which is really important in patients that come in with, any abdominal or hepatobiliary biliary pathology. I think beyond this, really clarifying if this is more acute to subacute, it seems like there's a background inflammatory milieu of this case with the weight loss, but the jaundice and the abdominal pain and the distension, or it seems like more distension than pain actually, seems to be more acute. And whether that's just the subacute process catching up to us in real time, or whether that's an acute change, I think will be helpful to differentiate. And I think those are my initial thoughts. And beyond the altered sleep, I'm not exactly sure what to do with that. I imagine with people that feel ill, you just don't tend to sleep as well. Whether you have if anyone had a flu or a cold or just not feeling well, you might be able to sleep as well as you normally do. But in the setting of jaundice and altered sleep rhythm, you definitely could bring hepatic encephalopathy to mind. And that's something I'm sort of keeping in the back of my mind. But I think I'm putting a little bit less diagnostic energy into that at this time. And we'll see as the case progresses if we're going to have to invest more cognitive energy in that. But I'd love to know, Mengyu, what you're thinking with all this information.
Yeah, I love your thoughts. And so, yeah, with the additional abdominal symptoms, definitely focusing on the thinking is more likely the direct hyperbilirubinemia, and for that we have hepatocellular or cholestatic. So for if the degree of bilirubin or alkaline is like a super high compared with the transaminases, of course, it kind of points towards the cholestatic picture, in which case we will we'll use some imaging to assess for the presence of extrahepatic. If not, then we will look at the intrahepatic, like infiltrated process or something like that. But I'm also kind of with the altered sleep, also like thinking about whether this is part of the hepatic, like cirrhotic picture, or hepatic process with liver failure with the hepatic encephalopathy. So I think definitely hepatocellular involvement is still like in the back of my mind. That will help clarify the degree of that. So yeah, that's where my mind is, and with the concern, especially the dark urine, the clay color stool, definitely. I think that itself like points more towards the cholestatic picture. So that, like my next question, and with the weight loss and the abdominal distension, kind of wondering if there's a cancer obstructing, like a severe inflammation, which is a cancer malignancy here, either in the pancreas area or biliary, like some intra-abdominal process obstructing there. So yeah. I don't think the past medical history adds too much to my differential for now, but I'm curious to hear more.
Okay, sure. Vital sign is temperature 37.1, heart rate is 70, BP is 130 over 90, respiratory 20, O2 saturation 97%. General non-acute distress, HE anti-score ejectus present, CV pulmonary within normal limit, abdomen distended, shifting dullness by percussing from the midline to the flank, palpable hepatomegaly, no tenderness, no splenomegaly or umbilical caput medusa on standing, just to look at the portal hypertension, and skin diffusely jaundice, most prominent on chest and back, orange yellow to greenish yellow in 1 week, muscle wasting, no excoriation mark, no spider nevi on the upper body, neuro, no apraxia, no ostraxis, no decreased cognition. Should I continue with the lab?
I think this might be okay to stop.
Okay.
Meng, you want to tell us what you think, and then maybe I can add on.
Yeah, so looks like the vitals are pretty normal, which for me here further decreases a concern for like acute hemolysis. But then with the abdominal exam, again featuring distension and hepatomegaly here, I think really concern for a liver process that kind of also correlate with the altered sleep rhythm. And I don't think I'm seeing any asterixis yet, but would be curious on the exam if there's, yeah, I guess I just saw that there's no asterixis. Yeah. And then diffuse jaundice, yeah. Muscle, so I don't see any other signs of cirrhosis at this point other than the distension, which here points towards seems to, I think what I'm hearing is like there's fluid. Did I hear fluid shift or something? Which makes me wonder if there's a ascites rather than just the hepatomegaly explaining the. So I think with the ascites, with the hepatomegaly concern for a intrahepatic, maybe an infiltrated process. And so I think that's where my mind is right now.
Awesome. Excellent thoughts, Mengyu. I mean, I think when I see the case, I think initially you see the icterus, you get the hepatomegaly and the shifting dullness, and immediately my mind sort of went to cirrhosis and then the idea of portal hypertension. And then on this very thorough physical exam, the patient doesn't have other signs of portal hypertension. There's no splenomegaly. There isn't clear asterixis. The patient doesn't have any spider nevi. So we're getting a sense that there is some likely hepatobiliary involvement, but cirrhosis per se and chronic liver disease may not be on the hook. And then there's no edema either. And I think the description of the jaundice was particularly interesting. It seemed like the coloring was different on the back or the arms, or I think I missed part of it, but it seems like part of it were more orange or greenish if I was hearing that correctly. And I'm not sure how much diagnostic energy to put into that. I mean, I think sometimes when I think about hyperbilirubinemia, the idea of a hematoma and the fact that when it is absorbed can change colors on the skin and can lead to a rise in the bilirubin, although not to this extent likely, is somewhat interesting. It makes me wonder if there is a sort of a bleeding propensity here, or whether this is just all noise and whatever reason the discoloration is just on a little bit of a different spectrum. The lack of asteristics now, if the hepatic encephalopathy grade is early on and it's just sleep disturbances, you may not see that, but it's certainly something to track. And it's good to know at baseline she doesn't have it. But as things progress, that could change. And then muscle wasting certainly helps you point to the chronicity of this. This hasn't really just been going on acutely. There's certainly more of a subacute or chronic tail of this. And certainly the shifting dullness is highly suggestive of ascites, and whether that is from portal hypertension alone or whether that is related to a potential malignancy, for example, I think we're going to have to find out. And, I guess the vitals are normal for now. This is just important in time. But I think for now, this is a 75-year-old woman with likely sort of intrahepatic or extrahepatic cholestasis, but certainly some intra-abdominal process that's driving all this with a sort of inflammatory, subacute inflammatory background. So I think the labs here are going to be super helpful. Just do they have a significant anemia? We finally get to define this pattern of likely liver injury a little bit more, and to really hopefully make some more diagnostic progress. But certainly all our money here is on the abdomen, and I think the labs and then certainly imaging after this will hopefully give us a little bit more information. But for the patient, for now, is stable, so we have a little bit of time to think this through. But I think Himuna, I'd love to learn more.
Yes. Okay. So the lab, WBC was 17.7. I cannot find the deep count, I'm sorry. Hemoglobin is 10, MCV is 82, platelet count is 150K, sodium is 128, potassium is 4.0, calcium is 9, BUN is 9, creatine is 0.89, PT is 17.9, INR is 1.7, but patient is taking apixaban for atrial fibrillation, you know that. And liver function, AST is 110, ALT is 70, lipase is 85, albumin is 3, and albumin globin ratio is 1.03, which is a little bit low, and alkaline phosphatase is 622, and gamma GGT is 421. Direct bilirubin was 15, and increase in 1 week 23.3, and the procalcitonin was 1.9, and I will stop here.
Okay, wow. So the white blood cells are quite elevated, 17.7, which I think just supports an underlying inflammatory etiology, whether that's infectious or malignant. Otherwise, the MCV being on the lower end certainly would potentially point to iron deficiency, or though anemia chronic disease could also be at play. There isn't significant thrombocytosis, which is interesting of in itself, but certainly in tracking the white blood cells, the differential, we don't have it, presumably be neutrophil predominant, but I think my suspicion for a funky inflammation is a little bit lower this time, but something to keep an eye on. The hyponatremia overall is fairly mild, so I'm not really putting that much into it. It seems like the patient hasn't been eating much, they're vomiting, so I expect it to be lower. And then we finally get to the liver chemistry tests here, and the AST and ALT are both elevated, particularly for an older woman, but seem to be profoundly cholestatic in nature, just with the severity of the alkaline phosphatase elevation. And maybe just to clarify, so the total bilirubin peaked at 23.3, is that right? And how much of that was direct? Do we have that information?
Yeah, direct bilirubin was 15 in admission,
15, okay.
and in 1 week later, it was a 23.3.
The direct?
Yes, direct.
Okay, and what was the total bilirubin, do you know?
A total bilirubin, I wasn't able to find it, sorry.
That's okay. So, I think for the purposes of this diagnostic exercise, we'll just presume it's all direct for the most part. So we have direct hyperbilirubinemia at this point, which based off our physical exam and what we got from the history, certainly puts us in the liver and the hepatobiliary system. So now we need to figure out, is it intrahepatic and extrahepatic? And the imaging, particularly looking at biliary ductal dilatation, will help us with this. I think the other patient symptoms with the nausea and the vomiting and the ascites definitely just requires cross-sectional imaging to be sure we're not missing a pancreatic mass or something else that's going on. Yeah, I'm not sure an ultrasound enough would be sensitive enough to know that we're not going to miss anything else that's in the abdomen. But I'd love to get Mengyu's thought on that as well. And then as far as the coags, yeah, I mean, the INR, it's a little bit difficult to interpret because apixaban can increase it. I totally sort of spaced when I was talking about the different discoloration of the jaundice and how that apixaban can be affecting things. But it's something I would just monitor for now and kind of go from there. The procalcitonin, I'm not getting a clear sense of an infectious site at this point, besides something maybe potentially intra-abdominal. And I'm actually not certain for the laboratory if that procalcitonin is elevated or not. I think in my laboratory, I think 0.5, anything above that would be elevated. I'm not sure about Hemoon's lab. So I would have to learn a little bit more about that. But yeah, I'm thinking for now we have intrahepatic cholestasis and we need to figure out why, and imaging will be the next step. But Mengyu, I'd love to get your thoughts.
Yeah, I don't have too much to add. I agree. The lab, the bilirubin, super high bilirubin alk files, but versus the relatively low AST/ALT kind of points, clearly points towards a cholestasis picture. And our next step is to figure out whether it's extrahepatic or intrahepatic. I think there are some clues for intrahepatic based on the portal hypertension and the hepatomegaly. So that's. But regardless, I think the next step is really to get imaging, and we can always start with an ultrasound, but the CAT scan has a little bit higher sensitivity. MR, and then MRI would have even higher sensitivity on top of that. So I think next step is really to get imaging to clarify the cholestasis process.
Okay, we did some little bit more lab before that imaging. So because the patient's hemoglobin was low, we did iron level and transferrin saturation. They were within normal. Serum ferritin was mildly elevated. LDH was 294, which is mildly elevated. Negative viral serology and autoimmune markers. And sarcoidosis, AC, and alpha-1 antitrypsin deficiency, anti-mitochondria antibody for primary biliary cholangitis, and ceruloplasmin for Wilson disease, they are all within normal. And we did worry about patient having a cancer, so we did a tumor markers, which is AFP for hematocellular carcinoma, CE for colon meta. They were within normal, and CA119-9, which is pancreatic cancer. It was elevated 106. And also CA125, which is ovarian cancer, but also can increase in liver cirrhosis. It was elevated 140. And we did the ultrasound guide paracentesis. We removed 1,360 millimeter ascites with no growth. It didn't really show the spontaneous bacterial peritonitis. But portal hypertension was identified. It was SSAG was more than 1.1. And then ultrasound showed hepatomegaly, no stone, no bile duct dilation. And because of the increased WBC and elevated procalcitonin, we start with the antibiotic, ceftriaxone, and the spironolactone, and furosemide, and albumin for ascites, and the lactose and rifloximab for early beginning of hepatic encephalopathy. And I'll stop here.
Yeah, so now we have some imaging. I think the image we actually don't have we do have the ultrasound that showed hepatomegaly, no stone, no bile duct. So there's no sign of obstruction on the ultrasound. Of course, we want to explore that further. We have to kind of further rule out extra hepatic obstruction with additional imaging like CAT scan and MRCP perhaps. But that just give us the initial impression that, well, maybe this is indeed intrahepatic. And then, however, I do see the lab showing abnormal CA19-9, which is one of the, I think it's a pretty more specific compared with some other tumor markers. So that definitely caught my attention and wondering whether this is a pancreatic cancer. And even though we don't see that on the ultrasound, but also I've heard that pancreatic cancer can be very hard to catch initially on imaging, especially with just an ultrasound. And even with advanced imaging like CT scan, it can be really sneaky. It may not even show up on the imaging initially. So I think we have to explore that further, maybe like even go all the way up to our ERCP. But then CA125, I think it's a little bit non-specific. It can be positive in any intra-abdominal fluid. So I don't necessarily, although classically, like we connect that with ovarian cancer, but I'm not thinking about that here. I think more like the either biliary or pancreatic cancer, I think is something we have to rule out. What do you think, Alec?
No, excellent thoughts, Mengyu. I think the ferritin being elevated just speaks to the underlying inflammation. I'll tell you, the tumor markers, I think they have a lot of value in their ability to, help prognosticate, especially for recurrence. But as far as they're used to identify cancer, they're just a little bit non-specific. There's a lot of other intra-abdominal pathologies in the abdomen related to the pancreas or the ovaries that can just increase the levels. And actually, one of the first cases that Reza and Robbie, I heard them discuss in person was a person with tuberculous peritonitis, and they had a very elevated CA125. And there was a lot of discussion about whether or not the patient had ovarian cancer, and they astutely told us that probably not. So I'm not saying that's not possible, but I think it just speaks further to the need for more high resolution cross-sectional imaging, particularly look at the pancreas and some of the other adjacent organs, just knowing that the ultrasound isn't going to be sensitive enough. And as far as the paracentesis, definitely needs to be done. And really is something I probably should have mentioned before, that spontaneous bacterial peritonitis can be extremely sneaky. Like 30% of people at least do not have abdominal pain. Some say that the number is even a bit higher. So the fact that the patient has new hyperbilirubinemia and has ascites, they need a TAP even if they have no fever. And the leukocytosis would definitely be concerning for that. So I'm really glad Hemoon's team was on top of that, just because the morbidity and mortality associated with that diagnosis is extremely high. So I'm also really struck that portal hypertension was found, which is in of itself isn't surprising. But the most common cause of portal hypertension is cirrhosis, right? So typically you would see other stigmata of that on exams. Splenomegaly would often be present. And a lot of times when people have very significant portal hypertension, the platelets are also low, which they're not here. It's not perfectly sensitive, but it is more specific. So I'm a little bit struck. It seems like the degree of liver dysfunction might be out of proportion to the portal hypertension. If the patient doesn't have cirrhosis, I'm sort of wondering, do they have non-cirrhotic portal hypertension? And the INR is a little bit, like we said, hard to interpret because of the apixaban. So, the ascites, the serum albumin to ascites gradient is pretty good to point to portal hypertension, but I think I'm a little bit struck about what exactly is causing that. And I think we'll have to do some more investigation. And just like you mentioned, Mengyu, I think right now we're pretty attached to the idea that this is intrahepatic cholestasis and trying to figure out what's driving that. And Hemoon and her team did a really thorough evaluation for secondary causes of cirrhosis, including autoimmune etiologies and genetic and whatnot. And those have all been unrevealing at this time. So I really think the next step here is to get additional intra-abdominal imaging and probably make our way down the track, right? So we start with ultrasound, then we go to CT, then maybe MRCP, then maybe ERCP, then probably biopsy, unless there's some other signal that we get along the way. And for a patient like this, that looks on paper as vital signs to be okay, but the white count is up, the procalcitonin is elevated. I think it's not wrong to treat for an infection. And me being in their shoes, I probably would. I would just be asking myself, like, where is the patient infected and what is causing it? And so I think the CT will also give us some additional progress or additional assistance there to maybe make a little bit more diagnostic progress. But and I think just as an aside, since I frequently miss this, understanding our host a little bit better, I think would be great. So an HIV test, I think, would be profound. And then I would love to know old labs. Is this anemia fairly new? Is this leukocytosis new? Is this something that has been more chronic? And I think those trends can be very useful as well as we make our diagnostic journey. But I would love to learn more.
Yes. Thank you for a great discussion. And in this ALCA, you get a lot of hint. CT scan revealed enlarged liver measuring 22 centimeter in length, irregular nodular growth up to 3.8 centimeter, scattered across the right lobe, heterogeneous hepatic attenuation suggesting passive venous congestion, and there was a 3.1 centimeter cyst lesion in the tail of the pancreas identified as intraductal papillary mucinous neoplasma, and I think that's the reason why the patient had the increase of CA19-9. But this MRI, it will give you a hint. MRI is very superior for evaluating liver disease, and it showed multiple nodule with a hyper-intense T1 and hypo-intense T2. I will stop here, and I gave you a great hint, which will cause hyper-intense and hypo-intense. Usually regular cancer, like for example, colorectal cancer, will give you T1 hypo-intense and hyper, like other type of tumor type of display hypo-intense T1, but this one, and then hyper-intense T2, but this one was opposite. And you have to consider about the past medical history.
Okay, actually interesting. And then Hemoon, just so I know, how many more aliquots are available before the final
one
diagnosis?
left. The result, the last one.
Okay.
Will be.
Okay, so the next aliquot will reveal the diagnosis, or okay. Well, Mengyu, hopefully you know more than me. I'm sure that this is a clue from heme, but I don't think this is something that I have ever seen. And so I'd have to be in real time Googling what can cause T2 hypointense lesions. And honestly, the other day I was just looking up sort of T1 versus T2 because I'm just terrible at reading MRIs. But T1 basically makes the fat bright on an MRI, and T2 makes both the fat and water bright. So I think that the T2 hypointensity means that there's, I don't know, either necrosis or I don't know, absence of water in that said area. I could, in that instance, I could think about maybe about deposition diseases, but like if you think about the heavy metals, we're not really getting a sense of like copper or like hemochromatosis or anything like that, because the Wilson studies, although not are imperfect or are not positive, if human is giving us a clue about the past history, and for some reason my mind keeps going back to the sort of discoloration of the skin, like being not classically for jaundice. I guess you could like maybe bleed in your liver a little bit and get, I don't know, some necrosis or something from that. I don't really know, but I'd have to say that I honestly don't know what's going on. I would just be frantically Googling like T2 hypointense. I'm sure this is characteristic of something, and the radiologist put this in their read, and I would just be relying on that and calling them to really get a sense of what's going on. And as far as making diagnostic progress from here, I think if after reviewing the literature and the scans, we're not able to make a diagnosis that way, I'm not sure of any other clear serologic test that I would be looking for. So I probably would be going for a biopsy unless there's another clear etiology otherwise. But Mengyu, please educate me more. I don't really know what's going on.
Yeah, I don't know if I know more than you, but practically I will call the radiologist to say, hey, what that mean? But we don't have a radiologist right now, so I'm like, my next step is to while Alex is discussing, I was basically typing into my chat GPT asking what liver lesion or liver cancer causes this, hyperintensity. So the chat GPT gave me the answer that melanoma could do that because what it says? It says melanoma contain melanin, which can cause T1 hyperintensity due to the paramagnetic properties of melanin and cause T2 hypointensity due to its dense cellularity. So maybe that's where, and then you mentioned about past medical history. Sorry, Alec, what did you say about the skin, like hyperpigmentation? I might have dismissed that during the.
No, I feel like Himuna in her description of the skin said that like some part of the skin looked green or something. Did I just completely mishear that?
Yeah, so I wonder if that's another clue for like melanoma or something. I'm trying to see what else ChatGPT told me. But I think multiple liver lesions definitely feels like a metastasis instead of a HCC. I forgot what the MRI finding for HCC, but sounds like it's maybe the other way, like it wouldn't be this specific T1, T2 presentation. So I have to read more about liver mass, but yeah, I kind of trust ChatGPT at this point.
And then because there seems to be nodulars, there's something called like nodular hyperplasia or something of the liver. I don't know if it can do multiple or if it's just one. But yeah, I mean, I feel like at this point, beyond a biopsy or sort of clear radiographic findings, I'm not sure what more to do to make the diagnosis. So I'm really looking forward to learning from this Casey Moon.
Yes, Mengyu, you're amazing. And ChatGPT, you're amazing too. Yeah, so she had ocular surgery 30 years ago. It was a uveal melanoma. She had a surgery and chemotherapy, radiation. It was remission for 30 years. She didn't have any problem. And 30 years later, she started to have a jaundice. Like the reason that I want to tell you guys that orange yellow to greenish yellow is how like big change, she was having the direct bilirubin is highly increasing. Yeah, so that was my intention that I want to tell you that the skin was changing. But yes, so she had a uveal melanoma, and then because of that, it was a meta to the liver. So we did a liver biopsy, as Alex mentioned, and pathological examination so strong positive for HMB 45, which is the human melanoma 45, XOX10, and the MART, which is melanoma antigen, the T cell marker were positive, and like cytokeratin A13, which is the marker of a carcinoma, were negative. So the diagnosis was the melanoma from uveal melanoma and melanoma metastasis in liver. Yes. So, ChatGPT said that melanin, right? I mean, it is right. The melanin cause decrease in T1 and T2 relaxation time of proton, resulting in hyper-intense T1 weight and hypo-intense T2 weight signals. In contrast, other type of tumor typically display hypo-intense T1 weight and hyper-intense T2 weight signal. So the management for this patient, unfortunately, it's extensive liver metastasis and the rising bilirubin signal the end stage 4 malignancy. And therapeutic ERCP or immunotherapy is not going to help her. So given the poor prognosis, the patient chose hospice care. And the oncologist mentioned that maybe she will pass away in like 2 months.
Wow, what a case. Like you said, 30 years ago, the patient had an ocular surgery, and then all these
Yes.
years, and then now the patient presenting with metastasis to the liver. Wow. Feel sorry for the patient, but this is like the first time I've seen this.
Yeah, really sad to hear about the patient, but thank you for sharing, their journey. This is incredible learning, and I guess I would just be curious. There was no other sites of metastasis, only the liver.
Yeah, I mean, we could do the more, endoscopy to find out whether there's other, like meta, but she really didn't want to do anything more because
Mhm.
her prognosis is so poor. So yeah, she gave up everything and we couldn't go further more.
No, I totally understand. I'm just trying to reflect, with my reasoning here and something that I would have thought otherwise. Yeah, I mean, I think clarifying what the ocular surgery was and what it was for, I think certainly would have potentially been a clue. And then, the magnetic, the MRI findings was just a gap in my knowledge and something that I'll have to add, but I think is, super helpful. But yeah, I mean, I think melanoma is always humbling. Can pop up anywhere at any time, and doesn't follow the typical lymphatic or sort of hematogenic spread patterns. Can just go anywhere at any time and cause, unfortunately, very devastating disease. And the eye, in particular, is so difficult because a lot of it you can hardly even see. And it's not like you'd have a scar in the skin, right? And you would be more likely to remember it. It's just something that people would sort of log away and not think much about, and always humbling. Yeah, I don't know if Mengyu, you had any additional thoughts or reflections here.
Yeah, no, I was also, I think it's good learning for me because I didn't know about the specific MRI findings for these different liver lesions. And I was asking ChatGPT to tell me about the MRI findings for different liver tumors. And I'm reading, indeed, as you taught us that like for hepatocellular carcinoma or liver metastases, or even like hemangioma or focal nodule hyperplasia, like the common liver tumors that we see, they're always like T1 is hypo-intense or iso-intense in some of those, but like T1 is hypo-intense and T2 is hyper-intense. And this is really a unique MRI finding. So I'm learning a lot from your case. And I'm also reflecting on the role of ChatGPT in our medical education and clinical reasoning, because this morning we just happened to have a grand round at our hospital about from Dr. Adam, what's his last name? He's the
Rodman, yeah.
Adam Rodman. Yeah, he's a host of the bedside rounds. So he actually gave us a talk about ChatGPT or AI in clinical reasoning. So I was kind of just reflective of that grand round, and then now using ChatGPT to help me with this learning and solving the case. So yeah, a lot of learning. I still have a lot to read about melanoma, about liver mass here. Thank you so much, Heemun, for sharing the case.
Yes, thank you so much. And then I guess we can pass it to the awesome Elena for the teaching points.
Hi, everyone. Hey, Heemun. Thank you for presenting such an educational case and great discussion, Mengyu and Alec. Yes, we started off with jaundice that we usually translate to hyperbilirubinemia, and Alec shared with us that it usually shows up on the skin or on the eyes when it's greater than 4. We typically divide hyperbilirubinemia into direct and indirect, whereas in indirect, we usually think of hemolysis, and in indirect, we think of intra-abdominal processes. The thought that this could be an intra-abdominal process was supported by the fact that the patient had abdominal distension and also signs of ascites. With the abdominal distension, we like to think of what is going on in the abdomen. We think of solid processes like stool or mass, liquid processes like ascites or blood, and gas that could be due to a perforation, for example. So when we have hyperbilirubinemia, we actually, before we get the labs, we can get some very distinct clues to direct hyperbilirubinemia. That could be acolic stools and dark urine. Usually a direct hyperbilirubinemia requires assessment for cholestasis, especially in the absence of pain. We have to think of a mass that could be in the abdomen. The patient presented with that jaundice and the weight loss, and usually those are symptoms that develop over a certain amount of time. So we knew that this was not a very acute process, but more likely subacute or chronic. The patient also had an altered sleep rhythm, and sleep disturbances are actually a very known symptom in cirrhosis, but also we have to be cautious that this could be a sign of hepatic encephalopathy and needs to be ruled out. Heemun shared with us that in the clinical examination, there weren't really any signs of cirrhosis, but likely ascites. And with ascites, we should think of cirrhotic and non-cirrhotic causes of the ascites and the portal hypertension. And for non-cirrhotic causes, we should especially think of peritoneal processes. Yes. The labs then revealed a cholestatic picture with direct hyperbilirubinemia, and this is usually a point where we need imaging to rule out intra versus post-hepatic pathology. Alec shared a great pearl with us that with tumor markers, they usually have a very low specificity, but they're great for monitoring patients that already have a diagnosis of cancer. The SAG over 1.1 usually, not usually, it does indicate that the patient has portal hypertension with actually a 97% accuracy. Causes can be cirrhosis, but also heart failure, hepatic metastasis, etc. A low SAG typically is found in peritoneal processes and also pancreatitis. From a management perspective, ascites usually requires an abdominal paracentesis. So, but to make it concrete, like every new onset ascites needs paracentesis, as well as each ascites that the patient is admitted for to the hospital, especially signs of infections to rule out SBP. Yes, and then Heemun shared the MRI with us. That was definitely definitely for someone who is very advanced in radiology. But ChatGPT is of course very advanced with this and said to us that the hyperintensity in T1 and hyperintensity in T2 is likely due to a melanoma. Yes, thank you for letting me do the teaching points and great discussion.
Amazing teaching points, Elena. Thank you so much for that. And thanks to Heemun for presenting the case. And thanks you so much for Amal for scribing a while on words. And to Mengyu, as always. We missed you, Austin, but hopefully next time. Thank you so much, everyone, for joining. And I hope you all have a great day and take care.
Thank you all. Take care.